Today you're going to hear from a family planning clinician and a consumer about an important health issue, heavy menstrual bleeding. Figures suggest many Australian women are having hysterectomies for this condition rather than less invasive treatments. The Australian Commission on Safety and Quality in Healthcare has developed the first nationally agreed standard of care for women with this condition. I'd like to introduce Clinical Associate Professor Deborah Bateson, the Medical Director of Family Planning New South Wales. Deborah was also a member of an expert working group which developed this clinical care standard. So why do we need a heavy menstrual bleeding clinical care standard?
So a clinical care standard is a user-friendly resource. It's made up of a small number of high-level, nationally agreed quality statements which are based on best available evidence. And what they do is describe the care that health professionals and health services should be providing to their patients for particular conditions, and actually also the care that patients can expect to receive. Now, these are not full clinical guidelines. They don't take you through every step of the management pathway. What they do is address the priority areas. So appropriateness of care is really at the centre of quality improvement, how we improve quality of healthcare across Australia. And that means giving the right patient the right care at the right time, and that includes for heavy menstrual bleeding. Now, the Commission's Atlas of Healthcare Variation is a really important document because what it does is it maps where healthcare is being provided with where people live. So one of the procedures that the Atlas looked at was hysterectomy. So what the Atlas found was that there was quite considerable variation, and in fact a 6.6-fold variation between the highest rates, which are in the inner and outer regional areas, and the lowest rates, which are in the big cities, the metropolitan areas and the remote areas. And there was actually an even higher variation when it came to the less invasive endometrial ablations. So what this suggests is that maybe women are not actually being necessarily offered or being aware of these less invasive options.
I'd now like to introduce Dr. Karina Lim, a GP who's experienced heavy menstrual bleeding. So Karina, tell us a little bit about your experience with this condition.
So for me, heavy menstrual bleeding started after I turned about 30. And it was a gradual thing. So I had my first child when I was 31, and then I had my second at 33, and then my third at 36. So in between each pregnancy, my periods got heavier and heavier, and then shorter and shorter, till after my third, things started to get quite bad. I was looking to where the toilet was. I was glad that my office was right next door because I'd have to get up and change super tampons every 2 hours. Then I actually took to wearing pads as well, just to be on the safe side in case I couldn't make it to the toilet in time. I'd watch where I would take the kids out. So if we were going out to a park, I'd make sure I knew where the toilet was. So it was really quite difficult each time of month.
So in your view, what's the most important part of the clinical care standard?
I think the most important thing is bringing awareness about heavy menstrual bleeding to women and to GPs, and that it's something that's often undiagnosed and untreated, because women, either it happens gradually where they don't realise that it's getting to a point that it's really affecting their lifestyle until it becomes completely unbearable, or it's something that they've always lived with, so they don't realise that it's, I guess, considered abnormal. The next thing I think is really important, that women be able to feel comfortable to have that conversation with their GP about their periods, and that GPs are open to having that discussion, asking the right questions, giving them advice and giving them all the options about the treatments that are available, whether it be medication or other less invasive things, before a woman gets to a point where they just would like to have a hysterectomy.
So I think the most important part really is that statement around shared decision making, and that affects every single part of the management pathways. But the other one to highlight is the statement that says about initial management being pharmaceutical. That highlights that a lot of heavy menstrual bleeding, once we've excluded malignancy and serious causes, can be managed in the primary care setting. But the other thing is to make sure that when you actually identify heavy menstrual bleeding, making sure that her next period is not going to be as heavy, even while you're waiting for an ultrasound or waiting for a referral, if that's going to happen. Start tranexamic acid or a non-steroidal anti-inflammatory, or even a contraceptive pill, just to make sure that you provide that symptomatic relief.
Hysterectomy used to be really the only option for women with this condition, but there are now some new, less invasive treatments. Can you take us through those?
One of the main ones is the hormonal IUD. It's inserted into the uterus, and the very low dose of levonorgestrel hormone thins out the lining of the uterus, and many women become amenorrheic. The other procedure is called endometrial ablation. It's been around for a long time, but we've got new generation techniques now which are minimally invasive, and what that does is remove the lining of the uterus. So we know that many women think that hysterectomy is actually the only option for them. Often they've been, told that by their friends perhaps, they've read about it, other people have said, oh, that's the way to go, and they're just unaware of these other options.
So how relevant is the clinical care standard to primary care?
GPs are at the front line of detecting heavy menstrual bleeding, taking that history when someone comes for a cervical screening test, for instance, obviously carrying out an appropriate assessment, organising investigations. But then the key thing, of course, is once you've excluded malignancy and serious pathology, the vast majority actually of heavy menstrual bleeding can be managed within the primary care setting. It's really useful to know that each of these standards comes with a companion fact sheet, one for clinicians and one for consumers. They're really helpful, and what we know is that many of the primary healthcare networks, the PHNs, are actually incorporating these resources into their health pathways.
So at what point should GPs be thinking about referring their patients on to a specialist?
So I think there's 2 points. So the first is when you've done your initial investigations, if you've got any suspicion of malignancy in particular or serious pathology, and that's particularly for women over the age of 45, we know that there's an increased risk then of uterine cancer. But otherwise, if you're managing the heavy menstrual bleeding in primary care, maybe with a contraceptive pill, maybe with a hormonal IUD, it's incredibly important to review them at 6 months or earlier if they, if things are not settling down, and if there's no improvement in their symptoms, then that's the time that referral is warranted.
So for GPs assessing a patient who might have this condition, what are the important investigations that they should be doing?
So it's important always to exclude pregnancy, but then it's about thinking about blood tests. Importantly, we need to assess for iron deficiency and anemia. We might want to do thyroid tests if indicated by the history or coagulation profile, as well then as a good quality transvaginal ultrasound.
Why is it so important to get the timing of the ultrasound right?
We do know that optimally we need to organise that pelvic ultrasound, a good quality transvaginal ultrasound, between day 5 and 10 of the cycle. It's when the endometrium is thinnest, so we're going to be able to pick up structural problems like polyps. And what we do know from our gynecology colleagues is that sometimes women end up having to go back for second, and I should say sometimes even more ultrasound, because that timing hasn't occurred.
So the standard says that IUDs are the most effective option for managing this condition. How important is it that doctors feel they're well trained enough to insert the device themselves?
We're certainly getting a lot more GPs wanting to learn this skill, and a lot of new GPs coming through GP training are taking that up, which is fantastic. So I think the key thing is to ensure that within your practice, obviously take up training or provide them yourself, but if you're not providing them yourself, have a rapid referral pathway. Have someone else in your practice who can do it, and if there's no one in the practice, ensure you know someone locally, a family planning organisation, a local GP, nurse practitioners, who can actually insert that IUD in a timely manner.
So Dr. Lim, how has having this condition yourself changed how you approach patients?
Since the clinical care standards came out and I was asked to be involved, I've actually noticed that I now routinely ask women about their periods in more detail with general screening, things like pap smear cervical screening. So normally I would have just asked, are you having a regular cycle? Are you getting any extra bleeding in between or after sex? But now I actually ask, and how are your periods going? Are they heavy? Are they painful? And then I actually find that there's quite a few women that I pick up that are now saying, yeah, but they've always been like that. And then that then prompts me to ask further questions like, how often are you changing? How's it affecting your life? And those kind of things. So it's been an eye-opener.